Bismillahirrahmanirrahim. Let's start with presentation for today, which is about acquired muscle disorders. I know it was sent out as a myositis, but I will talk a little bit deeper too, but hopefully you will enjoy it. Let's start with the first case. So 66-year-old female with past medical history of lumbar stenosis who presented an ED for evaluation of fatigue, leg weakness, and confusion for 2 weeks. Patient initially began experiencing low back pain in July. Noticed that she was having some accompanying tingling, numbness, sensory symptoms in lower extremities. So thinking about just something going on in the legs, she presented to the ED for similar complaint and was diagnosed with low back pain, and she was discharged. Then she had progressively worsening of the weakness, to taking a cane to ambulate, now to the point that there is safety at stake in terms of ambulation. On examination, she was having left hip flexion 3x5, right hip flexion 4x5, left foot dorsiflexion 4x5, right was fine, distally diminished deep tendon reflexes in lower extremities with the intact sensation. And I have some timeline highlighted. You can see the nerve conduction done in October of 24. So looking at the sensory study of this, and there are normative numbers given just below in the box. So you can look at the peak latency of all those nerves. So the only abnormality is that left ulnar amps are slightly low. So when you look at the abnormality, you always question, is it technical or is it true low? So look at the temperature. Temperature is normal, appropriate for the study. So the technical temperature factor is out. Now looking at the piece, look at the amp done at the wrist is 6.7, one done at the elbow, distal to olecranon process is 6.3, proximal to olecranon process is 6.6. So that is technical. Why? There could be a conduction block there. So 6.7, 10%, even if you don't take 0.6, it's going to be 0.7 or 0.6, but it didn't drop that much. It dropped by 0.4, and then it picked up again, right? So looking at those, then the other criteria, which are the additional things you can look for, is the duration, which I didn't. So looking at the latency, amplitude, and velocity is basic. Looking at the duration is more advanced. Okay, so the duration didn't change too much, because if there is a temporal dispersion, conduction block, that should change. It didn't change as much, from 6.6 to 6.2 to 6.0, which makes me feel it is technical. What could be the technical issue then? Because it never ends there. Now looking at that, 6.7 to 6.3 to 6.6, there is a difference of supramaximal stimulation. Now look at the F wave, because the F wave latency is normal for the left ulnar. So there are other factors to look at to think, is it truly abnormal as abnormal or technical? Like the duration and the F wave latency, the conduction velocity, even looking at the velocity, okay, that is fine too. It's in the normal range. And it didn't change too much between 62 to 68. And proximally, arm is warmer too. So that's why I feel that is technical. Okay, so what happened here? The sensory and the motor study, including the F waves, are normal. That's how we're going to say. Right? But the patient had the weakness. We knew that. This is the EMG. So whenever we look at the EMG table, it has two parts, if you look at that. Okay, you look at the left side, which is the spontaneous. You look at the right side, which is recruitment and motor unit action potential. Okay, recruitment is something very fine. It takes extra time to really document recruitment. So basically what we look at is spontaneous and the morphology of motor unit action potential. So the spontaneous gives us the idea about the active denervation, and the right side of the table gives you the idea about the chronic denervation. Somewhat diffuse, seemingly both sides, and whenever we think about the lumbosacral radiculopathy, think about the common lumbosacral radiculopathy is L5S1. They're seemingly more involuntary, right? So there is not only tibialis anterioris involved, there is quadriceps are involved too, which makes me feel that, femoral nerve is involved, is upper lumbar is more involved, and by the pattern of presentation, that's why it's putting one piece at a time. History, examination, nerve conduction EMG, and other pieces. So thinking about this intermittent problem or chronic problem with acute and chronic presentation, proximal more than distal, asymmetric weakness, and active denervation changes. Seems like that? So there are no sensory or motor findings. And believe me, just as a disclaimer, I personally don't, when I put these studies for you guys, all these years and even in the future, whatever I reported, I present the same. Even if I have done the mistake, I will accept it because that's an ongoing process of improvement even for me. So this is exactly what I reported, okay? So we can look at the report. Now look at I mentioned technical difficulty. Patient is drowsy and inability to perform voluntary action, okay? So that may be another reason I was not able to get a lot of spontaneous chronic activity like motor unit action potential. This patient was inpatient and we were not able to posture the patient to do the paraspinal muscles. So that was one limiting factor. Beside the other, the patient was not able to perform. So if you didn't mention those limitations, how would the audience or the reader know the setting of the patient? You got me? Okay. So that was kind of, but I still could have done the upper extremity, but we'll talk about that. One, in this patient, clinically patient didn't have a whole lot of weakness or mention of weakness in the upper extremity. Upper extremity exam was normal, but still needle study could have been performed in the upper extremity. Okay. They're reported as diffuse active denervation changes in lower extremities. So I kind of pointed that out. Proximal more than distal with absent F waves recording in bilateral peroneal nerve. Okay. The differential diagnosis may include acute myositis, diabetic amyotrophy, bilateral lumbosacral plexopathy, or radiculopathy. Okay. At this point, because of the limitation of the study, we didn't put down ALS, but it could be. Okay. But remember, there is a whole kind of discussion for each and every word or differential that is mentioned there. These were the labs for the patient. Pancytopenia for unclear reason, seemingly, but platelets were very low. Hyponatremia, some elevated ALT, AST. So there is some kind of autoimmune process going on here, right? ANA is positive, okay? CT scan, with and without, normal. ESR is high, CRP is high, which also goes with some kind of inflammatory, autoimmune, neoplastic, big differential. So there are subtle differences when you are looking at these cases. So that's why there's a lot more thinking and brainstorming in neuromuscular. Okay. Remember, if there is a perimesenchymal or fascia changes in the muscle, aldolase goes up. If there is a muscle fiber like myofiber breakdown, CPK goes up. And in some processes, both of them don't need to go together. So if aldolase is high, think about something periseptal dermatomyositis, kind of the term comes in, okay? If it's just the CPK, think about the myositis. But again, these kind of overlap, but having both, you guys may have me on the service, and I always request few things together. Like I asked for ESR and CRP, never asked for one. I asked for CPK and aldolase, never asked for one. So there are reasons, okay? This case, we did the nerve conduction study on 9th of October, and this panel which guided us came up almost a month later. So this is important because as we talk about time is brain, muscle is brain, I think how swift a physician can get to the diagnosis is very important to save the disability. In neurology, we are thriving for disability. Many times people are not dying, It's the disability we are trying to save in these patients. So, and that's why I want to talk about a few things during presentation about the role of MRI and whatnot. MRI femur with moderate muscular edema and atrophy involving all compartments of bilateral thighs as well as musculature proximal consistent with myositis. This was done on 16th. After on EMG, like a week later, we already proven those findings. Okay, that's bladder, we already know that. So looking at this, so what we look at stir images, it may come in your right exam, maybe. Now it's much more used, so you may come across this. So if we are doing the fatty replacement of the tissue, that gives you the chronicity. You got me? So they call it moderate edema and atrophy. They didn't call it there are fibrosis yet, which proves it. So whatever, as I said, I'm very critical about what I do. I could be wrong, but how I improve? By going back and forth, correlating things. Okay? So this was done on 16th, a week later after the EMG. Same. Those were the coronal cuts. These are the axial cuts. So looking at this, okay, these are your vastus lateralis, okay, vastus medialis, and then adductor muscles here on the inner side, okay. These are your vasculature, femoral artery, vein, whatever, your femur. But again, you look at that, they again call it edema, but again, these were the T1 and it's not done without contrast. So looking at that, you can still, I agree, you do see atrophy. So those are the septi in the muscle that gives you idea about the atrophy. It's not the hyperintensity or the inflammation part of it. Now, pathology done, reported on 1st November. Okay. They call it immune-mediated inflammatory myopathy. Okay. Diffuse type 2 fiber atrophy. Type 1 is red, type 2 is white. Fast-acting. Okay. They appear different on the staining. ATPA is 4.6 and 9.4, I believe. Okay. I'll show you some images. Believe me, it's not very easy to remember, but for the exam's sake, you need to. Okay. Now, they call it type 2 fiber atrophy, which goes with the fibers who are already at stake, okay, because of the fast component of them, okay. And they call it immune-mediated. Now, let's look through the details. So, findings include very rare and scattered degenerating and regenerating muscle fibers, most noticeable in formalin section with HLA upregulation, but no evidence of inflammatory infiltrate or myophagocytosis. So, see, they did see the atrophy, they didn't see the inflammation. Got it? Okay. The anemesium around these degen fibers, they call it degen and regen rather than the whole word. Save me for that. Focal positivity of alkaline phosphatase and complement, but no upregulation of acid phosphatase, which I'll come to that. There is no evidence of vasculitis, abnormal vacuolation, or inclusions. And again, it's important. Biopsy shows moderate variation in fiber size and demonstration of diffuse type 2 fiber atrophy with stains of ATPase. I'll come to the ATPase stain and I'll show you how does it look like. Now, this biopsy, thinking about timeline, nerve test was done 9th, MRI done 16th. This biopsy was done on 18th, reported on 1st of November. So both the myositis specific antibody test and your pathology result almost a month later. So hematoxylin eosine, looking at, so these are the septi, those fascia fibers. You do see these hyperintense by the fascia. Those are kind of degenerating fibers. Pycnotic is the other terminology. I used to like histopathology a long time ago. Yeah, my old love. So showing the degen region fibers in a perifascicular distribution, pretty obvious. So this is ATPase 9.4 showing the type 2 fiber atrophy. So remember that type 1 appears darker. It's kind of the reverse. I'll show you in the next slide. But so I think it's the by the perifascicular darker fibers are the type 2 maybe. Because between the 4.6 and 9.4 it flips. And it's always hard to remember. And I will not be able to remember that. Okay. The way I want you to remember hematoxylin eosine is very easy to remember. You know, the pink, we all know that. The brown is all ATPase. Okay. And Gomery trichrome, I try to remember by green. And NADH and succinate are the kind of purplish and bluish. I'll show you those. It's kind of like, what is it? And that will guide you, again, it's on the slide, that what to look for. So these are the HLA upregulation. Again, I just got it from the histopathologist. I don't know the details, how do the HLA upregulation kind of, but that kind of gives you some idea of MHC class activation. Okay. let's talk about the topic for today's discussion, and I'll give you this particular case. If you synthesize finally what kind of myositis, we kind of feel there is, despite there is not a whole lot of inflammatory cells, but there are degenerating fibers, regenerating fibers. There is some activation with the focal positivity for alkaline phosphatase. Okay, so no clear evidence of raging inflammation, but fibers are degenerating for some reason. Okay, and we do have those antibodies positive. So it's a antibody positive myositis. But remember, those antibodies are not myositis specific antibodies. That is the classification that I'm going to talk to you about. But the timeline is important. Understanding the whole process of thinking is important. So here we go. So there is no single perfect classification system for myositis so far. We call it dermatomyositis if there are skin manifestations. If there are antisynthetase syndrome, there are specific manifestations of that. Then there is if it's a fast progressive and necrotizing changes, and those are usually bad, as a matter of fact. I have seen some of those patients as inpatient, and those are, I'll say, they not only we need to act fast in those cases, but those are bad cases too. We really need to act fast on those. Immune-mediated necrotizing myopathies, and then overlap myositis. And our patient kind of fits in the group for overlap myositis, as a matter of fact. Remember, I said whatever is not documented was negative. So all those CCP, rheumatoid, SSA, everything was negative on this patient. Paraneoplastic, I know, we all try to throw in to make sure something comes out positive, some golden fish. So the usual approach is you look at the clinical phenotype, which we did discuss, asymmetric, proximal. Then you look at the next step is the antibody status, which takes time if you can get. And the third step is the histopathology. Okay? So those two steps take time, but the clinical phenotype is very important. In neurology, I know whenever I talk to students, residents, fellow, even in the national meetings, you will always hear the speakers talking about history, and again history.
Yeah.
An exam and the rest of the stuff is just to prove what you have come up with during the history, your differential. Okay. Now, clinically, proximal upper extremity, usually lower extremity, which was not the case in our patient, didn't have upper extremity. Neck, pharyngeal, diaphragmatic weakness, okay, and extraocular movements are rare. Okay. So the neck, pharyngeal, diaphragmatic, and extraocular movements are relatively rare in these patients. Now, thinking about those dermatomyositis, those are extramural manifestation. Extramural manifestations include heliotrope rash, Gottern sign, Scholl sign, poikiloderma, which is usually seen. I try to put this to remind myself too, because if in the right exam, remember those gonna be the keywords. Okay, so if you know the TIF1 gamma is the one, then you have to think about poikiloderma as a keyword in the scenario. Same goes for alopecia. I had a patient with calcinosis, so I always remember NXP1. So once you really see a case, then you kind of correlate it. Otherwise, it's a memory thing, and you tend to forget again and again. NXP with calcinosis, I will never forget because I saw that patient. Okay? Nail bed telangiectasias, and I never had an MI2 patient positive. Okay? Mechanic's hand, antisynthetase are the cases where the mechanic's hand with the hyperkeratosis and all. Oral ulcers, interstitial lung disease. Remember, it's more commonly with MDA5. Okay, so cardiomyopathy, anti-U1, GI, and nephro. And remember, our case was positive for anti-U1. Okay? CK can be normal with minimal or no muscle fiber. It was like, okay, so or normal. So please, as we discussed, aldolase is very important and it's high with the perimesium and fascia kind of changes or damage. So that was an ulcer on this side. This is the ulcer, okay? These are telangiectasias, okay? And hypopigmentation and periangular erythema. So next is, remember the antibody yield is 65 to 70%, so it's not 100%. If it's dermatomyositis, the antibodies are NXP2 and then TIF1 gamma, MI2, MDA5, SAE. antisynthetase, and that the photograph for the hand was antisynthetase positive patient. So I'll say I have seen all these syndromes now. So anti-Jo1, PL7, PL12, OJ, and EJ. Believe me, I have never seen these, so these are not as common. We all know Jo1 is more common. Immune-mediating necrotizing. I have seen one patient with SRP. I have seen one case with HNG-CoA, and mitochondrial, I haven't seen any case. So these are the main syndromes and the antibodies associated. For exam's sake, I believe you guys need to remember some of it. Okay, so just kind of try to imprint it a little bit. Okay, so rule out the mimics. That's the purpose of the nerve conduction in these patients. Extent of muscle involvement and selection of muscle for biopsy. But I usually don't go for biopsies as frequently like the nerve biopsies, but the muscle biopsy many times makes you, unless you have a real diagnosis, many times you need to proceed with the muscle biopsy, and you really need good histopathology team to help you out. Okay, so I highlighted for myself, believe me or not, I highlighted for myself, so much information to remember. MI2 is Hispanic individuals, that's how I go, okay? Type 1 gamma is like strong relationship to cancers. NXP2, calcinosis. MDA5, we already talked about the severe interstitial lung disease, Asian population. SAE with predominant Asian population. Antisynthetase, severe muscle involvement, which was the case in the patient that I saw. The rest of the antibodies, interstitial lung disease and severe muscle involvement. Okay, immune-mediated SRP, I saw that patient, those CPK could be really high with the myocarditis and respiratory failure. HMG-CoA, this is the tagline, only 2/3 of the patient with a history of statin use. So even there is no history of statin use, this could be a right exam question, okay, you still think about it. And antimitochondrial, again with the axial weakness and primary biliary cirrhosis. Imaging. So how imaging helps. We talk about how the nerve conduction study helps. I think that is faster. You can take it to the patient bedside and get some quick answers. You can do multiple muscle sampling. In case of imaging, it helps with the idiopathic inflammatory. So if you confirm that inflammatory myopathy early on with the nerve test, imaging can help you too. Guide about the muscle edema. We talk about the straight images, atrophy, or the fatty infiltration, which is the T188 images, but it gives you the pattern of involvement and guide about muscle for biopsy. Okay? Proximal, distal kind of thing. But you can get that information from the EMG too. So I feel MRI has a role, but then you have to move the patient down to MRI. Okay, you're not able to kind of image different regions like thigh and the calf or the arm. So that's, you cannot get the spread or the extent of the disease, but it sure can guide you about the muscle. And I have some other slide to share in the second case. So muscle edema is not specific for idiopathic inflammatory myopathy. Differential may include trauma, overuse, denervation, so even nerve issues, toxic vascular infection, inflammation. So everything is there. When everything is there, I feel that that test loses the value. Limitation, only one region can be tested at a time, need to mobilize the patient, and could be costly if you try to do multiple regions. Histopathology. Okay, so hematoxylin and eosinophil, analyze, as you said, like the muscle architecture. So this is the T1 of pathology. Identify rim vacuoles and inclusions. It doesn't give you a whole lot of detail, but it gives you the architecture. As I talk about the Gomery trichrome, I'm going to come to the images too, so don't worry. That's the next slide. It also gives you the idea about the muscle architecture, but it additionally helps you with the ragged red fiber. So thinking about mitochondrial. So if there is a Gomery trichrome, whatever the scenario is, they want to make sure that you interpret the architect and the ragged red fibers. That's more common. So do remember that piece. ADPAs, we talk about 4.3, 4.6, and 9.4. Hard to remember even for me, but those kind of flip. Then 4.6 and 9.4 flips. But it mainly helps you with the fiber type grouping and group atrophy, which is mainly for the genetic disorders. And type 2 fiber atrophy. Type 2 comes up with the steroid use, disuse. So those are the type 2 fiber atrophy commonly. Thinking about your fast muscles goes out quickly. They don't have enough reserves. Type 2 fibers. So when we are staining, 4.3 is for type 1 fiber, 4.6 is for type 1 and type 2B, 9.4, and remember it was brown and dark brown by the slide. okay, is type 2A and type 2B fibers. Mainly type 2A fibers we are looking at, okay? Nicotinamide, adenine, dinucleotide phosphate, NADH, which appear purplish and bluish. We'll see for central core, neurogenic process, and ragged blue fibers, which is another form of mitochondrial dysfunction, okay? This is not very commonly given in the exam scenario. Most commonly, it's going to be besides hematoxylin-eosin, it's going to be Montgomery trichrome. Let me tell you. Okay, cytochrome oxidase. Again, for inclusion body myositis is important. You look at that, and the mitochondrial disorders. PAS, okay, which appears pink. Again, if it's not hematoxylin-eosin, it's periodic SHF, and you're looking at the glycogen. So look at the vacuoles. So there are like rounded vacuoles. Okay, that is PAS stain. Think about glycogen storage disorders. Oil-Loreto or Sudan black, again for the lipid content, appears black. And then Congo red for amyloid deposits. I think that is another very common with the new therapies. That could be something in the exam. It could be in the nerve, it could be in the muscle. Acid phosphatase, we talk about that for the necrotic fibers. But alkaline phosphatase, remember it was given that alkaline phosphatase was high, despite there was no inflammatory cells in our case. So inflammatory myopathy in the perimysium and related with the blood vessels. Here you go. So remember, H&E is mainly for the architecture, for the basic information, right? And if you look at the fibers, those are big and then there are small. So if you look at, I agree, there may be slightly increased inflammatory cells or maybe those mononuclear cells, but it's not very high, okay? But most obvious feature is variation of the fiber size. And you can, I mean, those who look at the fascia and all can tell this is a little thicker than usual, but I will not pick anyone on that, okay? So connective tissue is slightly more too, but more obvious thing is the variation of fiber size. And this is what we talk about. The 9.4 ATPase is mainly for the type 2A fibers, and the type 2A are the dark ones. Okay, again, similar phenomena, variation of fiber size. These are type 2 fibers and these are type 1 fibers. As I said, it flips in 4.6, so it's hard for me to remember. Okay, so muscle biopsy with the Montgomery trichrome, as I said, is greenish. So as soon as it pops up, think about Montgomery trichrome. And in that, what we look for is ragged red fibers, right? What else we look for? Basic architecture. Okay, myofibrillar myopathy with non-hyaline lesions with amorphous appearance. Okay, denser in appearance. Okay, so that's kind of, again, this is a high-end pathological stuff. Even I won't be able to pick it up, believe me or not. I'll just say it's a Montgomery trichrome skin, right? Looking for the architecture, and you can see some fibers are really big, and again some are small, and there is some inclusion in it. That's all I can say. So those are the lesions. They put it down as a myofibrillar myopathy. This is NADH. Okay, again, as I said, it's a bluish, purplish, not very commonly in the exam scenario, in my opinion, unless it's a neuromuscular board exam. So again, in that, you usually look at the stain of a patient with the central core myopathy for the inclusions, okay? Then comes the pink. I know it's a little bit different pink, but it's really bright pink. And with periodic SHF, as I said, I go by P to remember pinkish appearance. For myocardials, for increased glycogen deposits, a lot of glycogen if you look through it. It's like filled with glycogen kind of phenomena in the muscle fiber. So subacute symmetric proximal limb girdle weakness by history and exam. Then the next step is looking for the muscle enzymes, okay? And also EMG. That is very basic at this point. You can do an MRI. I see rheumatology folks doing MRI early on, and I think it goes by axis too. But I think in neurology, we should go for the EMG first to get some idea of the disease process. But if those are normal, okay, unlikely, consider the differential. Okay, this is important, what I want to say. And I do get those consultations many times that the muscle enzymes are normal, are very mildly high. Then EMG didn't show any evidence. I will not go further. Is something else going on with that patient? It could be fibromyalgia. It could be something else, but not a muscle problem. But if there are any of those are abnormal, even one is abnormal, like thinking about EMG, or CK is elevated, or aldolase, then you can go to the next step. Look for those changes in case patients having interstitial lung disease, skin changes, looking for the antibodies, and based on the antibody, you can think about, is it like myositis HMG-CoA or SRP, or is it because of the dermatomyositis or antisynthetase syndrome? If you have the antibody positive, you stop there. If you don't get the antibody positive, proceed with the biopsy. As we talk about, the antibody yield is 65 to 70%. So I'll say in 30 to 40% of the cases, you still have to proceed with the muscle biopsy. And as we have seen, even the biopsy result came a month later and the antibody result came a month later. So probably most of the time we're gonna end up doing the muscle biopsy because we are desperate to know what's going on with the patient. I'll end there. All the best for you guys. And there are some interesting cases we can do in future.